Today we will discuss the urinary bladder. At the end of the lecture, the student should be able to discuss the apex, base, border, and surfaces of the bladder. Secondly, discuss the ligaments, blood and nerve supply of the bladder. Now, the urinary bladder, as you all know, is a temporary storehouse for urine which is getting emptied via the urethra. The external urethral sphincter is the sphincter urethrae, which is placed proximally in the wall of the urethra and not the terminal part of the urethra. In cases of pylorus and anal canal, the sphincters are placed at their terminal ends, but not over here. The sphincter is present within the wall itself. The male urethra is subserving the function of both urination and ejaculation, that is the expulsion of semen, and is about 18 to 20 centimeter long, whereas the female urethra is only 4 centimeter long. If catheterization is required, it is much easier in the female. Coming to the features of the urinary bladder, it is a muscular reservoir of urine lying in the anterior part of the pelvic cavity. The detrusor muscle of the urinary bladder is arranged in whorls and spirals and is adapted for mass contraction rather than peristalsis. Right? Coming to the size, shape, and position, the bladder varies in size, shape, and position according to the amount of urine it contains. When it is emptied out, like over here, it is lying entirely within the pelvis, but when it fills up, it is expanding and extends upward into the abdominal cavity, reaching up to the level of umbilicus or even higher. You can see the difference between the empty and the full bladder. The external features of the bladder. An empty bladder is tetrahedral in shape. It has an apex which is directed forwards, a base or the fundus directed backwards. It has a neck which is the lowest and most fixed part of the bladder. It has three surfaces, the superior one and the right and the left inferolateral surface, separated by four borders, two lateral borders, one anterior border, and one posterior border. In the full bladder, the shape of the urinary bladder is somewhat ovoid. The apex is directed towards the umbilicus, the neck directed downwards. It has two surfaces, the anterior one and the posterior one. Relations. Now, the apex of the bladder is connected to the umbilicus via the median umbilical ligament, which is representing the obliterated embryonic urachus. The base in the female related to the uterine cervix and the vagina. In the male, the upper part of the base is separated from the rectum by this rectovesical pouch that contains the coils of the intestines, and the lower part is related to the seminal vesicle and the termination of the vas deferens. The triangular area between the two ductus deferens is separated from the rectum by this rectovesical fascia of Denon-Willards. The neck is the lowest part and most fixed part of the bladder, lying 3 to 4 centimeter behind the lowest part of the pubic symphysis, a little above to the plane of the pelvic outlet. It is pierced by the internal urethral orifice. Okay. Now, in males, the smooth muscle bundles are surrounding the bladder neck and the preprostatic urethra. They are arranged as distinct circular collar, which with their own distinct adrenergic innervation. This preprostatic sphincter is devoid of any parasympathetic cholinergic system, and this is a part of the proximal urethral sphincter mechanism. In the female, the neck is related to the pelvic fascia, which is surrounding the upper part of the urethra. In infants, the bladder is lying at a higher level. The internal urethral orifice is lying at the level of the superior border of the pubis, and then it gradually descends down to reach the adult position after puberty. Now, the superior surface in males, it is completely covered by peritoneum, as you can see over here, and is in contact with the sigmoid colon and the colon and the coils of the terminal ileum. In the female, the peritoneum is covering the greater part of the superior surface except for a small area near the posterior border which is related to the supravaginal part of the uterine cervix. The peritoneum over here is reflected onto the isthmus of the uterus to form the vesico-uterine pouch over here. Coming to the inferolateral surfaces, they are devoid of peritoneum and are separated from each other anteriorly by the anterior border and the superior surface from the lateral border. Here, this is the posterior surface of the urinary bladder. It's the triangular area over here. You can see the upper part covered with the peritoneum, right? These are the seminal vesicles. This is the prostate gland. This is the seminal vesicle, and this triangular area. Okay, this triangular area is basically the fascia related to the fascia of denominators. In the male, each surface, this is the outline of the prostate gland, each surface is related to the pubis and to the puboprostatic ligament, retropubic fat, and the levator ani and the obturator internus. You can see this is the puboprostatic ligament from the prostate gland to the pubis, and then we have the retropubic fat over here. The levator ani muscle is over here, and then we have the obturator internus. In the female, the relations are the same except that the puboprostatic ligaments are replaced by the pubovesical ligament. So as the bladder is filling up, the inferolateral surface forms the anterior surface of the distended bladder, which is covered by peritoneum only in its upper part. The lower part comes into direct contact with the anterior abdominal wall, there being no intervening peritoneum. Now, this has an important clinical significance, which we'll read further on. Because of no intervening peritoneum, this part can be approached surgically without injuring the peritoneal cavity, right? So, just go through this little video for recapitulation of the urinary bladder.
And neurovasculature. So we're going to start off by looking at some sagittalish sections of the infraperitoneal area with our female model on the left here and our male model on the right. And of course our bladder is highlighted in both images in green. So the urinary bladder is a hollow, muscular, distensible organ of the urogenital system, and it's located inferior to the peritoneum within the lesser pelvis and rests on the pelvic floor. And in this image of the female, we can see the bladder over here, the uterus here, the ovaries here, and the rectum here. And over on our male model, we can see our bladder in green, the seminal ducts, and the rectum just here. And so the bladder's main function is to collect urine that's to be later voided by urination. And although the volume of the bladder varies from person to person, in general it can hold anywhere from 400 to 1,000 millilitres of urine, with the average capacity at around 400 to 600 millilitres. And so roughly about the same volume as a can of soft drink. So the walls of the bladder are composed of thick, smooth muscle called detrusor muscle, and this muscle is lined with a transitional epithelium internally, which in the bladder is called urothelium. And urothelium is a little bit special, as it also lines the ureters and parts of the ureter, and is also known for its high elasticity. So the body of the urinary bladder, shown here in a male pelvis on top and in a female pelvis below, is the portion of the bladder situated between the fundus and the apex. And the fundus being the inferior posterior surface or base, while the apex is the anterior aspect, which is located towards the pubic symphysis. So this of course is a coronal section of the bladder, but if we were to imagine a sagittal section, then the apex would be up front closest to us, coming out of the screen, near the pubic symphysis, and the fundus would be out the back going into the screen. Urine that comes into the bladder from the kidneys via the ureters is collected in the body of the bladder, and as the bladder fills with urine, it takes an ovoid shape and extends towards the anterior abdominal wall within the greater pelvis. The fundus of the bladder is the inferior part of the posterior wall, or the base of the bladder. And again, we're looking at a coronal section, but just imagine the green section just pointing out into the computer out back. And in males, the fundus is closely related to the anterior wall of the rectum, while in females, the fundus is closely related to the anterior wall of the vagina. And the fundus contains the trigone of the bladder, which we're going to talk about in the next slide. The trigone of the bladder is found on the internal surface of the fundus, and it's an upside-down triangular area of smooth muscle with its superolateral angles formed by the ureteric orifices, which we can see pointed out by these arrows. And these orifices are the openings of the two ureters in the bladder, and between them lies a membranous fold called the interureteral fold. And the interureteral fold is a fold of mucous membrane which has several other names, and these are Mercier's bar, the interureteric fold, or the interureteric crest. So the neck of the bladder is situated at the base of the trigone and is therefore the most inferior aspect of the bladder. Inferiorly, the neck of the bladder is continuous with the proximal urethra. And the urethra, which arises from the neck of the urinary bladder, is a canal for the transportation of urine from the bladder to the external urethral orifice, where urine exits the body. And here we have, of course, our cross-section of the female bladder on the left, and the male bladder and the urethra cross-section on the right. The female urethra is approximately 4 centimetres long, with its external opening situated between the clitoris and the vagina, while the male urethra is much longer and can be divided into 4 parts. The pre-prostatic urethra, which is the initial part of the urethra, and is only about 0.5 to 1.5 centimetres long, and is continuous with the neck of the bladder, which is just here. It's also surrounded by an involuntary muscle called the internal urethral sphincter muscle. The prostatic urethra, which is about 3 to 4 centimetres long, is continuous with the pre-prostatic urethra, and as we can see, it runs through the length of the prostate. The membranous urethra begins upon exiting the prostate, and it's about 1 to 1.5 centimetres long, and it is surrounded by the external urethral sphincter muscle. And here we have the spongy urethra, also referred to as the penile urethra. And the spongy urethra is the final portion of the male urethra, and it's continuous with the membranous urethra. And this part of the male urethra is the longest, about 15 centimetres, and contains the external urethral orifice. And of course, we can't leave without talking about the blood supply. So, the urinary bladder receives arterial blood supply from two branches of the internal iliac artery in both males and females. The superior vesical artery, which supplies the anterosuperior aspect of the bladder, and the inferior vesical artery, which supplies the fundus and the neck of the bladder. Venous blood from the bladder is drained via the vesical venous plexus to the internal iliac veins, and the veins covering the bladder, which are shown in blue in both images, are part of the vesical venous plexus. Innervation of the urinary bladder is provided by the vesical nervous plexus, highlighted in green in both images. So it's probably a good point in our tutorial here to mention the way urine is passed, and which is otherwise known as the process of micturition, as there are two ways that this can happen: via a parasympathetic or reflex action, called the micturition reflex, or voluntarily through the sympathetic system. So, in the case of the micturition reflex, as we've mentioned, the bladder can fill up to around about 400 to 600 millilitres of liquid. So, when the bladder is full, it triggers stretch receptors located in the bladder wall. And this occurs around 300 to 400 millilitres of liquid, although at 150 mils it can cause an urge, which is easily repressed. Now, once the bladder triggers the spinal nerves in the parasympathetic nervous system, the detrusor muscle is given the signal to contract, and the bladder expels urine through the urethra. With regards to voluntary micturition, however, motor control is provided by fibres from both the parasympathetic and sympathetic nervous system, but greater detail of this process will be covered in another tutorial. What will be useful to remember in this tutorial, however, is that the process of storing liquid and emptying the bladder are under the control of the sympathetic, parasympathetic, and somatic nervous systems, with storage controlled by the sympathetic system and micturition controlled by...
Okay, so that was just to give you an outlook of the bladder. Coming to the ligaments of the bladder, we have the true ligaments and the false ligaments. The true ligaments are condensations of the pelvic fascia around the neck and the base of the bladder. They are continuous with the fascia on the superior surface of the levator ani muscle. So we have the lateral true ligament of the bladder extending from the sides of the bladder to the tendinous arch of the pelvic fascia over here. So the lateral ligaments. Then we have the lateral puboprostatic ligament directed medially and backward, extending from the anterior end of the tendinous arch of the pelvic fascia to upper part of the prostatic sheath. Right here, prostatic sheath. This is the tendinous part of the levator ani. The medial puboprostatic ligament is directed downwards and backwards. It is extending from the back of the pubic bone near the pubic symphysis to the prostatic sheath over here. The ligaments of the two sides form the floor of the rectopubic space over here. In females, the bands similar to the puboprostatic ligaments are known as the pubovesical ligaments, and they are ending around the neck of the bladder. Right over here. Okay, you can see this is the bladder over here. These are the spaces formed, and these are your lateral ligaments over here. Now, this is the bladder. This is the median umbilical ligament, which is the remnant of the urethus, extending from the apex to the umbilicus. Right. This is the bladder over here. You can see the pubovesical ligament. Then we have the lateral true ligament of the bladder. We also have the posterior ligament, which we'll just talk about. It is directed backwards and upwards along with the vesical plexus of the veins. It is extending on each side from the base of the bladder to the wall of the pelvis. Coming to the false ligaments, they are nothing but peritoneal folds which are not forming a very substantial amount of support of the bladder. They include the median umbilical fold in the middle, and then we have the medial umbilical fold, that is the obliterated umbilical artery. We also have the lateral false ligament formed by the peritoneum of the paravesical fossae, the posterior false ligament formed by the peritoneum of the sacrogenital fold. Okay, this is the paravesical fossae, right? Yeah, paravesical fossae over here. Okay, here. This is the median umbilical fold. This is the medial umbilical fold. Median मतलब midline, and medial you all know. Okay, now coming to the interior of the bladder, it can be examined by cystoscopy at an operation or an autopsy, right? In an empty bladder, the greater part of the mucosa shows irregular folds due to its loose attachment onto the muscular coat. The small triangular area over the lower part of the base of the bladder has a smooth attachment to the muscular coat. This is known as the trigone of the bladder. The apex of the trigone is directed downwards and forwards. The internal urethral orifice, that is the opening into the urethra, is located over here. The ureters are opening at the posterolateral angles of the trigone. Their openings are around 2.5 cm apart in an empty bladder and 5 cm apart in a distended bladder. A slight elevation immediately posterior to the trigone to the urethral orifice is basically produced by the median lobe of the prostate called the uvulae vesicae. The base of the trigone, formed by the interureteric ridge or bar of Mercier, produced by the continuation of the inner longitudinal muscle coat of the two ureters. The ridge extends beyond the ureteric opening as the ureteric folds over the interstitial part of the ureters. Now, the mean capacity of the bladder in an adult male is 220 ml, varying from 120 to 320 ml. Now, filling beyond 220 ml causes the desire to micturate, and the bladder is emptied out when it is filled by 250 to 300 ml. Filling up to about 500 ml may be tolerated, but beyond this, it becomes painful. The referred pain is felt in the lower part of the anterior abdominal wall, perineum, and the penis. You know about the arterial supply, you have just seen it. The arterial supply is coming from the superior and the inferior vesical arteries, which are branches of the anterior trunk of the internal iliac artery. Additional supply is derived from the obturator artery, inferior gluteal arteries, and in female from the uterine and the vaginal arteries instead of the inferior vesicle. The venous drainage. Lying on the inferolateral surfaces of the bladder, we have the vesical venous plexus. Veins from this plexus pass backward in the posterior ligament of the bladder and drain into the internal iliac veins. Lymphatic drainage. Most of the lymphatics from the urinary bladder are terminating in the external iliac nodes. Few vessels are passing to the internal iliac nodes or to the lateral aortic nodes. Now, this topic is extremely important, the nerve supply of the bladder. Now, the urinary bladder is supplied by the vesical plexus of nerves, which is made up of fibers derived from the inferior hypogastric plexus. Okay, the vesical plexus contains both sympathetic and the parasympathetic component. Each sympathetic or parasympathetic component contains a motor and a sensory component. Firstly, the parasympathetic efferent fibers or nervi irrigantis. If S234 are motor to the detrusor muscle, these nerves do not supply the preprostatic sphincter. If destroyed, normal micturition is not possible. The sympathetic efferent fibers are said to be inhibitory to the detrusor and motor to the preprostatic sphincter. The somatic pudendal nerve supplying the sphincter urethrae, which is voluntary and situated within the wall of the urethra. Now, the pain sensation caused by the distension or spasm of the bladder wall are carried mainly by the parasympathetic nerves and partly by the sympathetic nerves. In the spinal cord, pain arising in the bladder passes through the lateral spinothalamic tract, and the awareness of the bladder distension passes through the medial posterior column. Bilateral anterolateral cordotomy, therefore, will selectively abolish the pain without affecting the awareness of bladder distension and the desire to micturate. Right. So you can see over here, this is the parasympathetic fibers, sympathetic fibers coming from S2 to S4. Right. Pudendal nerve sensation coming from the sphincter urethrae. Now, clinical anatomy, the interior of the bladder can be examined in the living by the cystoscope. A distended bladder may be ruptured by the injuries to the lower abdominal wall. The peritoneum may or may not be involved. Now, this is your hypertrophy trabeculae muscle. This the cause is chronic obstruction to the outflow of the urine by an enlarged prostate gland. Okay, so we have the suprapubic cystostomy in which the bladder is distended about 300 ml of fluid, right? As a result, the anterior aspect of the bladder comes in contact with the anterior abdominal wall and can be approached without entering into the peritoneal cavity. Now, emptying of the bladder is basically essentially a reflex function involving the motor and the sensory pathway. The voluntary control over this reflex is exerted through the upper motor neuron. As long as only one pyramidal tract is functioning normally, the control of the bladder remains normal. Injury to the thoracic or the sacral segments of the spinal cord leads to a state of spinal shock in which the muscle of the bladder is relaxed, the sphincter vesicae is contracted, but sphincter urethrae relaxes. The bladder distends and the urine is dribbling out. After a few days, the bladder starts contracting reflexly. When it is full, it contracts every 2 hours. This is called automatic reflex bladder. Damage to the sacral segments of the spinal cord situated in lower thoracic and lumbar 1 vertebrae results in the autonomous bladder, which is when the bladder wall is flaccid and its capacity is greatly increased. It is fills to the capacity and starts overflowing. So there is continuous dribbling over here. Also, the urinary bladder is one of the sites for stone formation as the concentrated urine lies here. So that's about the urinary bladder. Thank you.